RPA PAL is sponsored by an educational grant from Amgen, and we appreciate their support. Finally, be sure to check out the RPA website for upcoming webinars and events. And I will now turn this over to Dr. Giles, RPA PAL Chair.
Welcome everyone to the 2020 RPA PAL Forum. I'm PAL Chairman Harry Giles. We are really glad to have you. This is a virtual meeting, but the warm welcome I wanted to send to everyone is genuine from the heart. Hope you have a good time today. PAL stands for Policy, Advocacy, and Leadership. And these are the topics that we're going to be addressing today. Keep that webpage handy with the Zoom links. Once one ends, we'll be opening up a brand new Zoom meeting for the subsequent talks. We will try and keep to a schedule, but you can pause and fast forward your own feed. Again, also, like Amy said, a grant from Amgen has helped us with this. They also support us through the years when we were called the NCAP Forum, and we greatly appreciate their support. So we are adapting today to this virtual platform, but all along with the RPA, I want to encourage you to stay involved. If you're not involved, get more involved. It's a great group of people. They share a lot of knowledge. It's also an opportunity once we can get back together, hopefully soon, to make friendships that can last a lifetime. Today's topics are going to be dynamic with question and answer sessions. I hope you enjoy that format. So our first topic is going to be on leadership. And leadership specifically during the pandemic with COVID-19. We're going to get some interesting viewpoints. We have Dr. Alan Kleiger here today, who's clinical professor of medicine at Yale University School of Medicine. He's worn numerous hats in the public policy arena, including being an RPA past president. He's co-chair of ASN's COVID-19 response group. Dr. Lauren Sanchez is a partner at Georgia Nephrology. He's chief of medicine at Emory Decatur Hospital, and not surprisingly, recently named a top doc by Atlanta Magazine. And then finally, Dr. Jeffrey Perlmutter, who's our RPA president, who's in private practice in Rockville, Maryland. Greatly appreciate all of our panelists today. I will turn it over to Dr. Perlmutter right now. Thank you very much.
Thank you, Dr. Giles. It's my pleasure to thank you and your committee, Vice Chair, Dr. Nishant Jalandhar, and the entire committee for putting together this excellent annual forum, which I know will be somewhat different in the way we talk to each other, but I think everyone will find it valuable. I also wanted to thank everyone who is on, who participated in the virtual Capitol Hill Day. At least from my perspective, I thought it worked very well because of the virtual nature. We were able to have more people on than we've ever had before. And in fact, we have more people signed up for PAL, about double as we do when we have it in person. So thank you all for participating. Thank you to Harry and his committee for putting together this meeting. We're going to have more than one session about nephrologists as leader during this forum, and we'll try not to overlap. What we're going to focus on during the first session, I think, is the unique nature of nephrology leadership during this current viral pandemic. As we learned fairly early on, the kidney is, whether you want to call it a target organ or a significantly affected organ by SARS-CoV-2, it became a very big deal in the care of our patients and in the management of our patients, both on the inpatient and outpatient side. And we're actually going to take this from a global perspective all the way down to a local perspective with regards to how the nephrologist has had to be a unique leader during this public health emergency. To take us through the global and national perspective, really from a public health standpoint, will be Dr. Alan Kleiger, and I'll turn it over to him.
Hi. Hang on a minute. Steve, give me that invitation again. I missed it. I need to. The controls may be at the bottom left. Okay, I know I have it now. Thank you. So first, we want to offer a poll question, and I hope you all can answer this. How would you describe the impact of COVID-19 on your practice? Check the box whether you think it had a severe impact, moderate, mild, or no impact at all. So please submit your answer now.
Interesting, isn't it? So over half of us, there was a moderate impact, but if you include severe and moderate impact, well over 90% of us were affected by this pandemic in our practices. So really important for us to pay attention to. So let me start off by giving some sort of global information. The EDTA published fairly recently what the 28-day case fatality rate of COVID affected dialysis patients was. This is now in Europe. And as you see by these graphs, 25% of all patients who were infected with SARS-CoV-2 that were dialysis patients did not survive. Survival was 75%, 25% died. And if you broke that down into patients who were not admitted or admitted to the hospital, you see 5% of COVID infected patients who were not admitted to hospitals died, most survived. But among hospitalized patients, 33% died. And among hospitalized dialysis patients that were admitted to the intensive care unit, over 50% of them died. So this is a disease that has a very substantial impact on our patients. The Hammersmith in London recently published some of its data looking at over 1,500 dialysis patients that it surveyed. They found that about 20% of their dialysis patients developed COVID-19, that it was substantially more likely to occur in-center than for home dialysis patients, and that there was clustering in specific units and on specific shifts, strongly suggesting the spread of COVID-19 in the dialysis unit on shifts. And then finally, the Hammersmith noted high rates of nursing staff illness. So we knew, looking at Europe, that it was incredibly important for us to take the right steps to prevent our very vulnerable patients from getting infected. Compare that to the experience that is now reported out of South Korea. And in South Korea, where they did immediate screening, you know, they'd been very well informed by the previous SARS-1 infection and were prepared for pandemics. And as soon as there was evidence that this new infection was there, in South Korea, they started screening, and they screened most dialysis patients. The second thing is that they did epidemiologic investigations with tracking and tracing of patients. They then did cohort isolation. They had separate dialysis sessions, not only for infected patients, but for close contacts of patients with confirmed COVID-19. And they isolated both staff and patients. With that work, they found that transmission was remarkably controlled, that there were very few patients that appeared to have acquired infection in the dialysis unit, a marked difference from what was seen at the Hammersmith. These are very important facts that helped our CDC start to think about how to deal with this in a meaningful way. Steve, let me ask you to move the slides. Next slide, please. Then we did some investigation in New York City, our COVID-19 response group, at the height of the pandemic in the third week of April, went to look at the 7 major hospital organizations in New York to understand what this really looked like. And here's some of the data that we found, which is really remarkable. First of all, in terms of the number of ICU beds, if you look at these data, you'll see that overall there was a virtual doubling of the number of ICU beds that became available in New York. So in New York, these large hospital complexes with many, each one of these facilities are multiple hospitals. They created ICUs in operating rooms, in radiology suites, in procedure areas. Wherever there was available, they created ICUs and literally doubled their beds. If you look, for example, at Facility G, their hospitals together originally had a little over 400 ICU beds, and it went up to 800. Just imagine creating that kind of ICU capacity. If you looked at those ICU beds the percentage of ICU beds that were occupied by COVID-19 patients you see on that third line. And it was an average of over 80%, and in some facilities, 100%. So COVID-19 displaced virtually all other ICU needs in these places. And finally, if you look at the percentage of COVID positive patients in the ICU that had acute kidney injury and required renal replacement therapy, that's the bottom line. And you see that that spanned from about 27% to 65%. Amazing. So something around 40% overall of ICU patients had kidney failure and required renal replacement therapy. So this was a huge problem and a huge strain on the hospitals. Next slide. Now, the United States was different than Europe and different than South Korea in that we did not have testing available to us. And I know you'll all remember that testing and widespread testing really is only available here in June for 3 to 4 months after the start. The very first cases that were identified in dialysis units that were patients with COVID-19 and came from nursing homes. And that first knowledge came actually in Seattle, where a couple of their patients in 2 of their facilities died of COVID-19. And it was clear that these dialysis patients came from nursing homes that had widespread COVID-19 infections. And so the CDC sent a whole team of people to Seattle back at the beginning of the United States experience. And based on what we knew about spread, they helped Seattle set up a plan that would try to minimize spread in the dialysis units. And you see here what that included. It included, number one, asking patients to call ahead, not just appear at the unit, if they had symptoms that were compatible with this infection. They then planned ahead about how to deal with and separate and isolate those patients from others. They had face masks then that were put on all people who were symptomatic. Obviously, later weeks put on everybody, but originally on patients who were symptomatic. They managed them and assessed them in a separate area and looked at them differently, and then suggested that dialysis patients wait in their cars with cell phones to talk to the dialysis personnel so that there were no waiting rooms and there was no opportunity to spread infections before patients actually got to the dialysis unit. These are the very first efforts that CDC made to put together a plan to try to limit spread in the dialysis unit. Next slide. And they also talked about how to make sure that patients with either suspected infections, that is patients under investigation or PUIs, or those with confirmed COVID-19 were not exposed to other personnel or other patients. And the initial plan was separate those patients in a separate part of the dialysis facility, make sure they're at least 6 feet away from everybody else, try to put them into a separate room, but if a separate room is not available, put them in a separate area at the end of the line or in a corner that is separated by at least 6 feet from all other patients. Next slide. As infections evolved, it became clear that far preferable to that would be to try to find a shift or even a facility that handled exclusively COVID-19 positive patients, or on separate shifts, PUIs, before they were proven, but to really separate them not only distance, but in different shifts or in different facilities than other non-infected patients. Also, it's important to remember that this all started at the same time as the influenza. And it's important, if you're going to cohort, to make sure you're separating COVID-19 patients from influenza patients that you didn't want, obviously, to be cohorted and mixed with the COVID-19 patients because of cross-infection. Next slide. And most importantly, when COVID-19 is suspected or confirmed, the advice is to make sure that you talk to your local health department. In many states, it is now a requirement to report COVID-19 as a required infection. I can tell you that that requirement in Connecticut, where I live, happened this week. So there was no requirement for reporting here in Connecticut until now. Now there are some states that require it and many that do not require it. So the strong recommendation from the CDC was when you have infection, talk to your local health department, work with them to make sure that you're doing things that you're most comfortable with. Next slide. So let me now turn my attention to what happens in the hospital. And to get that experience, we spoke to several of those nephrologists in those 7 hospital complexes I mentioned at the top. And Dr. Michelle McCrickey from Montefiore prepared this set of slides that I'm going to show you that gives their experience in the pandemic. This is at a time at Montefiore where the dialysis requirements were 5-fold what their usual ICU dialysis requirement is. And so that they were critically running short of fluid, of machines, and of staff. And so the series of things I'm going to show you are guidelines that they came up with to try to minimize infection spread, but also to try to preserve equipment and fluids sufficiently to make sure that all patients who needed renal replacement therapy could get it. So first, she talked about what do you do to dialyze patients who are COVID-19 or PUIs who are intubated. And what they did was to make sure that patients are isolated in their own private areas. Hemodialysis was in their room using a portable hemodialysis machine with RO, and having the efflux go directly into a designated drain to prevent excessive splash. It's not been shown that dialysate effluent has virus, but this was the recommendation based on being as careful as you can. They washed down the dialysis machine with 1 to 100 bleach wipes, not terribly different than is usually done. And in fact, it's been shown that standard disinfection and terminal disinfection in dialysis facilities in the standard way, but done carefully, clearly is sufficient to kill these viruses. If the patient has not been coughing, or if it's been more than 72 hours since the patient was febrile, what they said is that patients can come back into an inpatient dialysis facility where they were cohorted on the last shift and treated in that fashion, and it was safe to do that. Next slide. In critically ill patients and patients in the ICUs, they were particularly anxious to make sure that these very sick patients got their dialysis treatments or their CVVH treatments, but didn't expose their nursing staff unnecessarily. One thing they didn't want is to have a nurse sitting in a small ICU room closed off from everybody else with an infected patient who usually was coughing, and even with appropriate PPI, they wanted to see if there were ways of better protecting the staff. So they were using extra long tubing to allow for the staff to be sitting outside of the room with glass windows looking in, and then with the machine located outside of the room with long tubing going into the room. Very interesting. It's not the way that the long tubing was designed. The FDA didn't approve the tubing for use in that fashion, but in a time of emergency, that's what they did, and they had a fair amount of success with that. They also realized that they needed to figure out how to make supplies last longer. And so while some facilities originally had been using 70 liters a day of CVVH fluid per patient, they reduced that down to shorter treatments. So they did intermittent instead of continuous treatments with CVVHD or with SLED, and also downsized the downside of it that required one-to-one staffing. They were running short of staffing because some of their staff got infected. So that was a challenge. Next slide. In order to protect the healthcare workers, they emphasized that patients remain masked during all RRT procedures. They maintain droplet precautions. They use full PPE. They specifically talked about limited direct exposure of the dialysis staff to the patient using extra long tubing. and, as I mentioned, baby monitors to remotely monitor patients during the hemodialysis treatments from the doorway. They also limited rounding of nephrology staff. So it wasn't, sort of these waves of consultants coming in and out of these rooms the way we usually see in the ICU. They limited the number of staff entering the patient rooms for physical exams, so one member of the renal team would do a physical exam. The communication with primary team members about patient complaints and exam and treatment plans were all done with that team all together with a single person in the room doing the physical exam. All hospital associates now wear masks the entire time in the hospital. Non-clinical staff use surgical masks. The clinical associates, people working in the rooms, are using N95s. And there are many hospitals that are now reprocessing N95 equipment so that it remains available for multiple use. Next slide. Staffing was a real challenge. This shows for hemodialysis off of the intensive care units before the pandemic in Montefiore, 8 to 12 staff per day were doing dialysis. By late March, that number had tripled up to 18 to 25 staff doing dialysis. And they had not been using acute peritoneal dialysis as an alternative, but given these shortages, they started using acute PD as one of the means of renal replacement therapy. 8 to 9 staff recruited to do that PD. So staffing issues really a problem. Next slide. And here are the adaptations that they described to the rising number of COVID patients that required renal replacement therapy. One is that they found they wanted to increase the threshold for renal replacement initiation. They used more potassium binders to treat hyperkalemia, more sodium bicarbonate to treat metabolic acidosis, diuretics to manage fluid issues before they actually initiated RRT. Once RRT was initiated, in many patients, they reduced hemodialysis treatments to twice a week when they felt it was clinically appropriate, shortened treatment times when it was clinically possible. They opened their inpatient hemodialysis units on Sundays and increased hemodialysis nursing staff on Sundays in order to accommodate this. So this was a huge change in their usual procedures. Next. Each hospital had multiple ICUs, and as I said, the vast majority of patients were infected with COVID-19 in those ICUs. And so they cohorted patients, machines, initiated more AKI patients on urgent or acute PD, and PD became one of the significant treatment choices. They purchased some more cyclers, PD cyclers, in order to accommodate that. And finally, they engaged more palliative care consultants for patients who were very ill and were unlikely to recover. Next. All right, so what I then outlined just now for you was overall what we learned, what happened in South Korea, what happened in Europe, what we learned from that, and how we tried using leadership and what we learned from around the world to really make the effect of COVID-19 and kidney disease as least deadly as was possible to do. So let me then turn this back to Jeff for the poll question. Jeff?
Thank you, Alan. So you're supposed to, we would like to know by what percentage did your office volume change? I won't read all the answers here. And please give your answers and we'll see how it goes. I guess everybody can see. So it looks like about a 50% decrease was the rough average here. I can tell you that my practice and the office at its low point hit about 1/3 of usual, and it's now starting to come back. A lot of that was dependent on there were almost no new consultations for a period of time because nobody was seeing their referring doctors. and I'm sure that their experience was was the same as well. Steve, can you remove the slide from the screen, please? Okay, well, we're not ready for questions yet. We're gonna talk a little bit more, but if you can take the poll question down. There we go, thank you. So I'd like to, thanks very much, Alan, for that global and national overview from a public health perspective. I'd like to sort of shift to more personal perspectives, but still from a leadership point of view, and emphasizing the unique situations that we've had as nephrologists, because as I had said earlier, this disease has provided some unique problems for us as nephrologists. I'm going to start actually with sort of a national organizational perspective, and I'll try to be brief with to be fair for time to allow for questions. But obviously, as a national organization, we need to continue doing the work of the organization. And you've seen many webinars that have come through, including this virtual symposium, moving forward. We've continued to provide guidance with respect to all issues related to the viral pandemic, such as telehealth. Where we had a unique issue for nephrology was that our specialty was faced with participation in new payment models that were the final submission of which, the final decision on which was due in October, and then were going to be implemented in January. And so we continue to provide guidance to CMS. Because our role here is to represent your interests, we actually queried our membership as to your perspective on whether this could continue. You were quite clear in that there was no way your practices were going to be able to implement new payment models in the middle of a viral pandemic. And we presented that information to CMS, CMMI in letter form. And as you know now, in fact, they have decided to delay at least until April 1st. And we'll take a little credit here. We were the only renal organization that asked for a delay in implementation. Of course, we want these models implemented, but we want them to succeed as well. So we did work on delaying the implementation. And for right now, there will not be implementation until the second quarter of next year. We've had to make decisions about meetings, as you know. I gave a video presentation, I will not forget this date, on March 10th, hoping against hope that we'd be able to have our annual meeting at its usual time. We were stuck in a very difficult place because there wasn't enough time to shift to a virtual by the time things got bad. So that's Tuesday, March 10th. Wednesday, March 11th, forgive my use of the vernacular, the world went down the crapper. And I didn't learn this from watching MSNBC, Fox, CNN, or any news station. I actually learned it from watching ESPN, because that's when the sports world shut down. And that's when you knew that nothing else could continue. By Thursday morning, we had already made the decision that we would not have our annual meeting. And how things will go for next year will depend, but at least we have enough time to do so. Taking this to the level of the community, with respect to the nephrologist, I think there are several unique situations, and Dr. Sanchez will join us to describe some of his experience with that. But unlike other specialties where they're dealing with office and hospital, we had the unique situation of outpatient dialysis. And Dr. Kleiger outlined sort of the measures that we were taking, but it really went beyond that. I think that our leadership role as nephrologists were as medical director for clinics, but even at the attending physician level, the nephrologist had to be an excellent team leader, because I don't know what your experience was, but initially there was a great deal of uncertainty among dialysis staff and including the administration staff. And often, even as the attending physician, one had to make a leadership decision about where the patient went. Fortunately, we were able to have cohort clinics that started fairly soon in my area, and I practice in Rockville, Maryland. And Maryland became a very hot spot, and my county particularly became a very hot spot And my part of the county where I mostly practice became a very, very hot spot. I'll describe in a minute. And so on the outpatient side, you had to become even more of a leader, both as the medical director and helping determine where people went, and also as the attending physician. And then there were the issues relating to inpatient dialysis. As you know, Dr. Kleiger described the situation in New York, which was probably the worst that we've had in the country. But I can tell you that in my part of Maryland, we were seeing a very similar increase, a little bit delayed in terms of number of patients in the intensive care unit and number of them in the ICU, and seeing the same rates of acute kidney injury. Now, in addition to being an outpatient medical director, I'm also the medical director of dialysis services for one of our community hospitals that actually happened to be the hospital that was the catchment area for the hotspots for coronavirus in our area. And specifically, as people noted, our patients were people with Spanish surnames because of the living situations and the need and the inability to distance work for that part of our population. And our hospital got to the bending point, but never broke. We never had to go to acute peritoneal dialysis, but we had a significant increase in the volume of hemodialysis, and also ended up having to triage. We're not a high volume CRRT hospital. We have only 2 machines at the time, and we actually had to get into the position of triaging, not within a palliative care or ethics situation, but just trying to get everybody dialyzed who needed to be dialyzed, and we had to implement procedures. And as the inpatient medical director, I had to be, a leader in that. And that the hospital where I'm the inpatient medical director actually happens to have an independent outpatient dialysis unit as well, which provided unique problems because we only have one satellite clinic. So we had no backup clinic. The satellite clinic was too far from our main clinic and didn't have really the space to take care of positive patients. So I had to work with the commercial providers to accept our patients into their cohort clinics so that we could run our units safely. With our hospital-based inpatient unit, patients have to traverse the entire space of the hospital. So we had to be extremely careful with our screening. And we had some people slip through because of breakdowns in communication between, for example, emergency department and the dialysis unit, that we don't appear to have had any transmission within the dialysis unit itself, and our staff was able to remain quite safe. And in the middle of all this, and this will help going forward, we are in the process of acquiring 4 machines that will allow us to do sleds. So we had 2 CRRT machines, and the rest we did with intermittent hemodialysis. And, it really wasn't possible to reduce the number of treatments per week because of how catabolic. And in fact, oftentimes we had to do people at least 4 times a week, albeit with shorter treatments because of how catabolic the patients were. And we didn't really even have the CVVHs run by our ICU staff, and actually we ran into limitations with the ability of the ICU staff to actually run this. So in the middle of all this, we're now acquiring 4 machines that will allow us to do SLED. And as the medical director, I had to participate in creating the order sets for that. So that was an additional responsibility as a leader in my hospital that I had to assume. And I'm going to turn this over now to Lauren Sanchez from Georgia to describe his situation, and then we'll come back for Q&A. Lauren?
Thank you for inviting me. At the beginning of the crisis, in the period when we were awaiting the coronavirus surge, there were many unknown risks that we were all assessing. We learned that COVID-19 was a very contagious process with a potentially high mortality rate, particularly for certain at-risk groups, such as the end-stage renal disease population. In Atlanta, Georgia, my colleagues and I closely monitored other areas of the country, such as New York and Seattle, as they managed overwhelming impacts on their respective healthcare systems. We were all getting mentally prepared. As a nephrologist, there was definitely unique challenges that I faced during this public health crisis. The adversity forced me to take on leadership roles in multiple settings. As a medical director at my dialysis clinics, as a partner in my practice, as a clinician dedicated to providing excellent patient care, and as an essential physician providing care in the hospital setting. On a personal level, I was managing anxiety related to my family's well-being, as well as the impacts on my community. Some of my neighbors initially treated me like I was radioactive due to occupational risks at the hospital, and they maintained a safe social distance of at least 20 to 30 feet while they thanked me for my service. On a professional level, I felt like I was preparing for battle. I was worried about my safety, my colleagues' safety, and the health and well-being of my patients. I had to overcome my anxieties in order to function in this environment. I provided reassurance to my patients, hospital staff, and employees within our practice. Amongst my colleagues, including other nephrologists in my group, hospital-based physicians, and other subspecialists, I focused on creating camaraderie and community by reaching out to them on a regular basis. I coordinated contingency plans with our chief of surgery, just in case we needed emergency peritoneal dialysis catheter placement. I identified advanced chronic kidney disease patients in my practice in order to ensure that these patients remained on my radar. On a practice level, we efficiently pivoted into telemedicine and provided the best care possible under the circumstances, while appreciating the technological barriers many of our patients faced, such as lack of an adequate cellular device or even internet coverage. At Emory-Decatur Hospital, the general mood changed fairly abruptly in mid-March when there was a surge of critically ill COVID-19 patients in our ICU. The hospital policies were continuously changing, reflecting massive uncertainty. For instance, it was initially forbidden to wear face protection throughout the hospital, including N95 masks, given concerns that this could create fear amongst patients and staff. I overheard arguments in the physician's lounge regarding employee safety and frustrations expressed about patient care-related issues, particularly related to inefficiencies with testing and triage-related issues. There was definitely heightened awareness about limited healthcare resources. Initially, there was minimal COVID-19 testing. The only patients getting swabbed were sick patients admitted with suspected illness. And the turnaround time for testing was about 5 to 7 days. This created massive uncertainty for a dialysis patient with a PUI designation. So a dialysis patient with symptoms concerning for COVID or even potential exposure was routinely refused care at their outpatient dialysis clinic and referred to the emergency room. Many of these patients were not ill enough to warrant hospital admission or even testing, yet they could not return to their outpatient clinic until they tested negative twice. Such patients were in limbo. Initially, there was no good solution, all at a time when our healthcare system was getting overwhelmed. As a nephrologist and medical director, it was my responsibility to help coordinate and advocate for our dialysis patients. I pushed emergency room physicians to perform COVID testing and help facilitate dispositions on a case-by-case basis. I closely coordinated with my nurse managers at my dialysis clinics regarding these issues. At the same time, my practice was in continuous communication with Fresenius and DaVita management regarding clarification for managing these patients. Our practice ultimately played a very important role in terms of coordinating and managing local COVID dialysis clinics and implementing new guidelines. In the ICU setting, nephrologists were essential in the management of the sickest COVID patients presenting with septic shock and cytokine storm. This included standard ICU management, as well as assistance with palliative care in some instances and resource allocation decisions. Many of these patients required intensive dialysis therapy on a daily basis, as mentioned previously. We implemented SLED therapy at my hospital in April in order to assist in the management of these ill patients. Initially, there were delays at my hospital obtaining this new dialysis modality due to lack of staff and training and contractual issues between the hospital and Fresenius. My practice's CEO, Karen Muro, and I helped expedite initiating SLED therapy after several intense conversations with hospital administration and upper-level Fresenius management. I also participated in the education of our dialysis nurses and ICU nurses about SLED, helped coordinate the ordering set through our medical record system, and importantly made daily decisions about dialysis therapy with limited dialysis machines and staffing constraints. I participated in daily COVID rounds at my hospital. Finally, I coordinated a meeting with our research division, which included Dr. Bill Paxton and Dr. Jim Tumlin, as well as several other interested clinicians, in order to share ideas regarding the pathophysiology of COVID and potential immunologic therapies. There were some really interesting ideas shared at this meeting. I know many of us face very similar challenges. I am grateful to be included on this panel to share my experience and to learn from my colleagues across the nation. Thank you very much.
Great, thank you. We are now going to go to Q&A. I will ask all of our panelists and moderator to come back on screen. And just a reminder to the audience, you may ask questions using the Q&A feature that most likely is at the bottom of your screen, depending on your device. So I see we have a few questions in the queue, so let's get started. Let's start with, are you seeing COVID fatigue in hospital staff on mask wearing and other infection control?
I'll take that. This is Jeff. I actually happen to think that the least safe place in the hospital is the doctor's lounge. If you ask me where there's fatigue, it's in the medical staff. Where I go mostly, they don't even give us wipes to clean off the keyboards. That's where people eat, so their masks are dropping, and then some people are not wearing their masks at all. I guess I think the rest of us are safe. I would say that in the hospital, I'm not seeing that. And in fact, most of the hospitals in my locale have actually moved from just from face mask wearing to requiring face shields for all patient contact. So they've actually ramped up. I do think there's a great deal of mask fatigue, pandemic fatigue in the community now. My county is a pretty liberal, progressive community, so the lack of mask wearing is not a political statement, but I think it's declined in the community much more so than in the hospital setting. And the God bless them, the dialysis workers have been 100% sticking to the protocols that they need to follow, at least as far as that I have seen.
I mean, just quickly to add to that, in New Haven, and we're in sort of the greater New York sphere, so we work pretty hard. Our nursing staff and other professionals in the hospital are still really carefully gowning and masking, and there's no evidence, I don't think, of any fatigue there. They've seen the deaths and they've seen the spread among staff. But likewise, as Jeff described, if you look around the community, we're clearly as a general community getting real tired of these methods. And in the dozen states in which the infection is now spiking, I'm very concerned about what that's going to mean.
Alan, I noticed you had a question for Lauren.
Yeah, I do. Lauren, you just described some wonderful leadership characteristics that you initiated, and I wonder what you did and what your thoughts are about nursing support. The nurses are the ones that are really on the line with the most time with patients, both in the inpatient, outpatient areas. More nurses were stricken than other healthcare professionals by this disease. So what did you do, or what should we be thinking about as leaders to support our nursing staff?
Well, in the ICU, my strategy was to actually learn all the nurses' names. I've been at my hospital for years, and I really didn't even know everyone's names. So I started by learning their names and spending a few minutes just talking to them about their concerns. They all had interesting, perspectives, and I think just talking to them was constructive, in terms of promoting a, positive environment. There's definitely a lot of nursing fatigue, and a lot of them still feel like they're not being optimally protected with lack of PPE. Some of the strategies you discussed about how we are using the tubing for IV drips and, monitoring the patients from outside the ICU rooms, I think was a positive change that we implemented as well at our institution in kind of end of March, early April. But those would be a few of the things I would comment on there.
Yeah, thanks.
Thank you. Our next question is for all of you, which is, have you had any issues with your staff or colleagues becoming COVID positive?
I will answer. So I've had no dialysis staff become COVID positive. In the hospital setting, actually very little transmission. I think a lot of the transmission to nurses occurred earlier in heavily hit areas where perhaps, at least based on the news reports, people were not getting access to appropriate PPE. At least in my area of Maryland, people had their adequate PPE. One of the ICU physicians did get COVID pneumonia and was hospitalized. He did well. He's back to work. And it wasn't my business to ask him whether that was an in-hospital acquisition or out of hospital. I do. One of our cardiologists got COVID and did not require to be hospitalized. He felt it was an out of hospital. And actually, two people that I cross cover with, not in my practice, but in a separate practice, became ill. I'm not going to comment on how they got it because it may have been something silly they did. They're separated by about 30 years. And the younger one was sick for about a day, and the whole family was quarantined, and they did absolutely fine. And fortunately, the older one is now doing well in rehab, but actually was in intensive care, was very, very ill. And so, yeah, there has been, I think there's been some, I think there's, when people have been careful in the healthcare setting with proper equipment, the transmission has been extremely low. I would just like to comment in terms of staffing. There was probably more dropout because of stress and fatigue than because of disease. My main hospital lost some ICU nurses, and actually that in-hospital dialysis program had 3 to 5 staff members drop out because they just didn't feel like dealing with it, and that put additional stress on the other staff. We just had to work through that.
Yeah. So in our area, early on, there were nurses and some doctors who became infected, but few. The hospital took really early action here. What it did, first of all, is it told clinicians, nurses, doctors, anybody else, anybody 65 years or older were not allowed to come to the hospital, interestingly enough. So it excluded the highest risk group of clinicians from exposure at the hospitals. The overall, in Connecticut, it's interesting to see what happens at the other side of the mountain, the way that Mario Cuomo describes it. On the other side of the mountain, past the local epidemic, a test of medical personnel here in New Haven, doctors with no symptoms at all, now show that 0.3% of us are COVID positive with PCR testing. So 1/3 of 1%. And doing antibody testing, about 5% of the general population in Connecticut have had evidence of infection. So there's still a very substantial vulnerability here.
3 of my colleagues had COVID during the last several months, one of whom was moderately ill. And these were at hospitals that I don't personally go to, but that had a big impact on our practice as we managed 3 of our partners having COVID. I would agree. At my hospital, I feel safest actually in the ICU, where it seems like everyone's taking extreme precautions. Everyone's wearing their masks. Everyone's paying attention to what they're touching. Definitely, we had several of our dialysis patients develop COVID, but no one who was critically ill amongst my patients.
Thank you. Our next question is, how receptive was your hospital administration to concerns from you and your colleagues regarding the guidelines? Do you have any tips to promote more effective communication between medical staff and administration?
I'll start with that. They're actually quite receptive, and I have to speak specifically about the hospital where I was the acute medical director, and we run our own program. So I do see a question in the queue about if it's run by an external entity, but we run our own program, including the chronic program. and they were very receptive. In fact, I had concerns that our infection control people at our hospital were not doing it right. As I said, we have an outpatient clinic within the hospital, and they were telling us to use ostensibly what would have been our hepatitis B room to treat positive patients, which was not going to work. And we had the full support of the administration. Also, hospital, for lack of a better term, is sort of a sanctuary hospital, and we treat a fair number of uninsured people, including on hemodialysis. About a third of our chronic population in the outpatient unit are people who are on emergency Medicaid. They came from the same area of the county where many of our patients who are sick in the ICU come from. And we have patients who do not yet have their emergency Medicaid, and we had 7 people coming through the emergency department on a weekly basis to have treatment. And clearly that wasn't tenable to have them come through the emergency department and perhaps have additional exposure. And we worked with the hospital administration to actually register them as as chronic patients. And their attending physician became our vice president for medical affairs, who's an obstetrician. And so actually they registered under her name, and we're able to come back and forth. And we had already committed to dialyzing all these people twice a week, not making them come in as emergencies. And that really helped quite a bit to get them on a more regular schedule and not having to come to the emergency department, but being screened for coronavirus when they came to the outpatient clinic.
I would say that our hospital administration was initially a little bit defensive. There was all these like changing policies. But fortunately, I think they became more responsive, over about a week into the height of the crisis. Our chief of staff, Adam Bressler, is fortunately an infectious disease specialist, and he became our point person for really communicating with the hospital administration. I had a few conversations with our CNO of the hospital, and he helped facilitate the sled therapy.
Great, thank you. I think this is going to be our final question. Our next question is for Dr. Kleiger. What are your concerns for our patients going forward, especially in the fall?
Well, like I just said, we know that even in places that have seen a lot of infection, that the majority of us and the majority of our patients are still very susceptible. We know that there will not be a vaccine despite all the hype, likely until the springtime, even if Dr. Fauci, my hero, is right and an appropriate vaccine is selected by the end of the year. To scale it up, to manufacture and then distribute enough and to get enough actual doses into us around the country is not going to happen in short order. So the important thing to remember in my mind is that most of our patients are still susceptible. There will not be a vaccine, and we cannot drop our concern about keeping the principles that the CDC is really nicely outlined that I went through at the beginning. Those are the things we really have to make sure we continue to do.
Great, thank you. And that is going to be our last question. I know we have some in the queue that we weren't able to get to. I'd actually encourage you to discuss this with your colleagues on our RPA Connect platform. But I'd like to thank everyone for joining us. Please close the Zoom window and return to either the conference homepage or email to launch the next talk, which will begin in 10 minutes. Thank you.
Amy, can I ask you a question out loud?
Yes, you may.
Can panelists stay on and answer questions by text after you close the session, or is that not possible?
I don't believe that's possible, but we did capture all questions, so I
Okay,
can
so
share them with you later.
we will try to answer those in time.
Yes, thank you all.
Thank you. Bye.
Thank you, everyone.